Assalamu alaikum warahmatullahi wabarakatuh, guys. Welcome back to the channel of summary of standard medical textbooks. That is nothing but standard medical notes. Let us finish this stuff, guys, today of respiratory failure. So the last topic of this is management of the respiratory failure. So let's begin with the name of Allah. So firstly, how will you manage a case of respiratory failure? So in any case of acute medicine, you will follow the ABCD EFG approach. So similarly, we will follow here. So I will just elaborate this. A means airway. I will get this here. Here. A means airway. B for breathing. C for circulation. And D for disability. I think, but the mental status of the patient. E for exposure. A B C D E. F for fluids. Okay. G for glucose levels of the patient. And Davidson furthermore expands this. This is according to Oxford up to G. Oxford mentions this, and Davidson gives two more things. H for hematology, meaning investigations, blood investigations, hematology, and I for infection. So this is how you proceed in any case of acute case of medicine. So I'll proceed here. So in the context of respiratory failure, we'll proceed. Okay. So whenever a patient presents with acute respiratory failure, you will know it by a pulse oximetry. Saturation will be less than 94% on room air. So first you assess the consciousness of the patient. Because if the patient is severely deteriorated, or if he is in type 2 respiratory failure, or if the patient is in acute hypercapnic respiratory failure, so his conscious mental status will alter. So first assess the consciousness of the patient. How you will assess? Gently shake and call the patient. If he doesn't respond on shaking and calling, that means presume the patient to be unconscious. Okay. You can also use a score called as ABPU score, which is very widely used in emergency medicine. So A is for awake or alert. Patient is alert. V is for patient is closing the eyes, but on voice, V is for voice. On calling the patient will open the eyes. P is nothing but pain. Patient will not open the eyes on calling, but on giving a pain. For example, you press the supraorbital area, producing the pain. The patient will open his eyes and make some facial movements also. And U is no response. Okay, that's how you assess. So if this is decreasing consciousness level, and when the patient improves, he will improve like this. Okay. So if the patient is conscious, then well and good. If the patient is unconscious, first of all, A for airway. Okay, clear the upper airway. How will you clear? Place the patient supine on the back. If there is no spine injury suspected in the patient, for example, in patients who have some cervical problems, or say a patient with RTA, road traffic accidents. So if no spine injury is suspected, perform head tilt chin lift maneuver. But this maneuver is prohibited in spine injury, because you can injure the spinal cord in those patients. Okay, how do you perform head tilt chin lift maneuver? Here it is, like this. Okay, in this form, just to tilt the head back and lift the chin. So what this will do, this will open the airways. The airway, because of decreased consciousness, the palate and tongue falls back. Because of that, there will be partial obstruction of the airway, and the patient will have snoring sounds, or if there is some snoring sounds. So to open that, you will perform this maneuver. Now if spine injury is suspected, you will not perform head tilt and chin lift maneuver. Instead of that, you will use only jaw thrust, and maintain the neck in neutral position. So how is this jaw thrust performed? Jaw thrust is performed like this. You hold the patient by both hands like this, and you will just press forwards. That is nothing but jaw thrust that will open the airway. Okay, there will be obstruction. By this maneuver is what you will do, you will open the airway, relieve this obstruction by tongue and glottis. Okay, this is the first you will perform. If there is any visible foreign body in the mouth, you remove that. If there are secretions, patient will have gurgling sounds, so you will suction that secretions. So that is about airway. Now moving on to if the patient has some obstruction, so he will sound, patient unconscious patient will have some sounds. So if he has gurgling sound, then it can be due to more of fluid secretion, so you have to suction that. If patient has snoring sound, he has soft tissue obstruction due to tongue or palate falling back. Okay, and this is very important. Stridor, the patient has inspiratory musical type of sound that suggests the obstruction at the upper airway at the glottis level, and it needs emergency tracheostomy. This needs emergency tracheostomy. If the patient has stridor, that suggests the patient has upper airway obstruction, and that needs tracheostomy, emergency tracheostomy. Or if you can't perform emergency tracheostomy, to gain the time, you will perform cricothyrotomy, something called as cricothyrotomy. What you will do, you will cut below the cricoid bone, above the first cartilage of trachea, below the cricoid bone, you will make a cut and place some instrument like this, blunt instrument like this. So for some time, this will be open after giving anesthesia. Okay, from this the airway, the patient can take breath for some time. Okay, if there is laryngeal edema, or if there is anaphylaxis and there is massive laryngeal edema, or something, for some foreign body is blocked at that level. So if there is no time for emergency tracheostomy, you will do this cricothyrotomy to gain time, and afterwards you will perform tracheostomy when you reach the proper center. Okay, now airway adjuncts along with the airway. So you can have aeropharyngeal or nasopharyngeal airway depending upon the gag reflex. If it is absent, you can gag. If gag reflex is not there, you can perform this oropharyngeal and nasopharyngeal air tube you can insert. Okay, now if airway is still compromised after performing these maneuvers and suctioning the secretions and removing the foreign body, so what you will do, if the patient is very much unconscious, GCS is supposed less than 8, and patient is not able to cough, patient is not able to retain or secure the airway, then you will intubate the patient. Okay, if unable, you can perform emergency cricothyrotomy in cases of upper airway obstruction, and tracheostomy is the definitive treatment. This is in cases of upper airway obstruction. That's about all about airway. Okay, now coming to breathing and circulation. B for breathing, C for circulation. So what you will do, after opening the airway, put your cheek on the patient's mouth and see whether there is air coming from the throat. If air comes, you will feel that breathing on the cheek. This is according to McMaster textbook of medicine. Okay, you will feel the cheek. If there is no air coming, and if there is no movements of the cheek, and if there is no chest rise, bilateral chest rise, and when you auscultate, if there is no air movement, there is no breath sounds, then assume that patient is in apnea. Along with this, you need to palpate the pulses also, mainly central pulses, carotid pulses or femoral pulses. Approximately for 10 seconds you should palpate. Okay, now if there is no breathing and the patient has pulse, what you will do, you will give risk breaths, 10 breaths per minute by bag and mask ventilation. You will give 10 rescue breaths per minute if the patient is apneic, but still you have pulse. And if you are in a, if the patient is in emergency department, you will opt an ECG also along with this. Okay, we will opt an ECG also. But now if the patient has no breathing and no pulse, that suggests the patient may be under cardiac arrest, then you have to start CPR, cardiopulmonary resuscitation. Okay, when the patient recovers, if the patient resumes breathing, place the patient in the recovery position. What is the recovery position? You will perform like this. Okay, see, like this. You will just move the hand towards the left of the head, like this. You're seeing, no? And you lift the leg, and you place the patient, like any fit patient, if he's any seizure patient, if he's having seizures, they will place the patient in the recovery position on the lateral side position. Why you are placing in the lateral side? So that the patient doesn't have obstruction due to secretion will pool, no? Those secretions should come out from the lateral side of the mouth. So for that purpose, so that the airway shouldn't block, you place the patient in the recovery position. While performing CPR, we'll assess every 2 minutes for pulse and signs of circulation. Okay, so that's about emergency management of respiratory failure. When you discover a patient, unconscious patient, who is not securing airway and who is unconscious, you need to do this first ABC. D is nothing but disability, nothing but the consciousness of the patient. So first you are seeing D only here. D, A, B, C. It is like that. And E is exposure. You palpate the patient whether the patient is febrile, whether the patient is exposed to some OP poisoning like that, and exposed, and you will wash the patient. You will remove the clothes of the patient, and you will wash the patient with the, by throwing water on the patient in OP poisoning patient. And if the patient is having some in morphine opioid poisoning, if has some fentanyl patch for some painkillers for some pain relief, and he is having that opioid poisoning, due to that you will remove that patch. That is the main goal of exposure. And you will see the temperature. Okay. E for exposure. F for fluids. You will look the BP of the patient. You will look the pulse of the patient. You will look the rhythm of the patient. So if the patient is hypotension, you will start the fluids. If it doesn't correct, and you look at the ECG, whether the rhythm is normal, whether the patient is not in ventricular fibrillation, ventricular tachycardia. All these you will see. Okay. Fluid level you will see, whether the patient is dehydrated, the limbs are hot, or whether the limbs are cold, whether the patient is in shock. These all you will see in exposure. Okay. G is for glucose. You will easily measure glucose by the portable mini glucometers. Okay. Because if the glucose value falls, so patient will be unconscious. Okay. So you will measure the glucose levels. H for hematology. You will send the investigations alongside, while not delaying the respiratory support. And I for infection, you need to have in the mind that infection may be cause for this failure. Okay. Now moving on to the main topic of on the context of respiratory failure, that is oxygen therapy. You will give after performing ABC, you will go to the oxygen therapy. That is the main topic we need to discuss. So what are the indications of oxygen therapy? If the PaO2 is less than 60 mmHg, or 6 kilopascals, okay, or if the saturation pulse oximetry shows less than 90%, except for confirmed or suspected hypercapnic respiratory failure, in those patients you will not start oxygen saturation at this 90%, because they will have hypoxemic respiratory drive. That's why you will maintain the saturation in these patients between 88 to 92%. So 90% is already in between 88 to 92%. So you will not give oxygen in these patients. You will give oxygen in these patients only when the saturation falls less than 88% on room air, and the target should be between 88 to 92%. Okay. So that is the second indication. Third indication, presence of clinical signs and symptoms of dyspnea, like tachypnea. So if you are not having some instrument to measure, and patient is dyspneic on seeing only, he is not able to talk in one full sentence. Okay, he is not able to talk in one full sentence, and is having increased rate of respiration. There is a recruitment of accessory muscles of respiration. So at that time, you will give oxygen therapy. If the patient is ischemic, like in chest pain, myocardial infarction, like in stroke patients, neurological symptoms patients, with neurological stroke patients, aortic dissection patients. So in ischemic patients, we need to give oxygen therapy. Okay. And long-term oxygen therapy, LTOT. So in advanced chronic respiratory failure patient, most frequently which we see is COPD, chronic obstructive pulmonary disease, less often by interstitial lung disease and cystic fibrosis. The most important uh, indication for long-term oxygen therapy which is given is COPD, obstructive pulmonary disease, not restrictive pulmonary disease. That is nothing but ILD, interstitial lung disease, and cystic fibrosis. Or sometimes in chronic heart failure patients and advanced cancer patients who block in those patients where the lymph vessels are getting blocked, and because of that they will have obstruction. Okay. Breathlessness. So in advanced chronic heart failure, most commonly in COPD, pulmonary indications I'm talking about, and then interstitial lung disease, cystic fibrosis, and if heart in advanced chronic heart failure, also you can consider giving long-term oxygen therapy. So these are the indications. Okay. So ischemia, dyspnea, PaO2, SpO2, and LTOT, long-term oxygen therapy. So how you will give long-term oxygen therapy? So I think this video will become prolonged, but no problem. This topic is lengthy. So if the PO2 is less than 55, or if the saturation is falling less than 88%, then always it is indicated that you give LTOT in patients of COPD. So in early stages, you will give LTOT only during night time, during sleeping time, when the respiratory drive is decreased. But as the disease progresses, then 24 hours you need to give LTOT. Okay. So some patients will have saturation between 55 to 60 mmHg, PO2, and SaO2 between 88 to 89% or 90%. You can see in these patients, when you will consider oxygen therapy, one of these should be present. So saturation between 88 to 89%, okay, or 90 you can take. So in these patients, if there are symptoms of cor pulmonale, bilateral pedal edema is there, raised jugular venous pressure is there, or hepatic congestion is there, tender hepatomegaly is there. So main one if sign, if I should say, is but if there is pedal edema in these patients, COPD patients, respiratory failure patients, so you need to give, you should suspect cor pulmonale, and you give you will plan for LTOT. Okay, if there is pulmonary hypertension, for example, there is ejection systolic murmur on auscultation, or there is right ventricular heave, these are all the signs, and you will confirm it by echocardiography. If the patient has pulmonary hypertension, then you need to plan for LTOT. If the patient has persistent erythrocytosis, polycythemia, nothing but hematocrit more than 55%, then you should plan for LTOT for these patients. So this remember, I am talking about the patients whose saturation is between 88 to 90%. Okay, in these patients, you will, if these three are not there, then you need not to start oxygen therapy, long term oxygen therapy, LTOT. If one of these is present, either cor pulmonale or either pulmonary hypertension or persistent erythrocytosis more than 55% hematocrit, then you will start LTOT. Now, if PaOT is more or equal to 60 mg, or saturation is more or equal to 90%, then if one of these is there, then you should start LTOT. Exercise limited by hypoxemia. Now, if the patient is walking, or if the patient walks and the saturation falls below 88% after walking or after exercise, okay, on exertion, if the patient's saturation falls less than 88%, then you should plan for LTOT. Nocturnal hypoxemia, when the patient goes on sleep, or during night time, if the patient is having breathlessness, or if the saturation is falling, if the saturation is falling less than 90 percentage, okay, 90 90 percentage, then you should plan for 90 or 94 percentage, sorry, okay. Hypoxemia is nothing but less than 94 percentage. So if the patient saturation is falling less than 94 percentage during sleep time or during night time, at that, in those patients also, you should start LTOT. So patient will go in this order only. So this is advanced stage, this is moderate, and this is mild stage. So more than 90%, either the patient should have nocturnal hypoxemia, or the patient should have less than 88 percentage saturation on exertion. Okay, these are the two conditions. Any of these two conditions should fulfill to have LTOT for patients more than 90% saturation normally. So that means first you should measure the saturation when the patient sleeps. So sleep time oximetry will decide these patients whether to have LTOT or not, or on exertion, exertion or sleep time. Now some patients will have saturation normally 88 to 90%. So in these patients, any of the three conditions should fulfill: cor pulmonale, pulmonary hypertension, and polycythemia more than 55% hematocrit. Cor pulmonale, pulmonary hypertension, polycythemia. Now if the patient, if during rest only he is having less than or equal to 88 percentage oxygen saturation, then you need to immediately start. No condition is required for starting this LTOT. Okay, these are the things you should remember. These are according to gold guidelines. Okay, now what should be the target then? You are starting, when you are starting oxygen therapy, supplemental oxygen should be titrated to target. In acute hypoxemic respiratory failure, the target should be 92 to 96 percentage. Okay, in hypercapnic respiratory failure, for example, in COPD, chronic respiratory failure patients, the target is 88 to 92%. So the concept behind that is, you should not deteriorate the patient by giving oxygen who is dependent upon hypoxemic drive for respiration. Okay, so this is the main target. In acute respiratory failure, it is 90 to 96%. In chronic, it is 88 to 92%. Special situations needing high FiO2, meaning more than 96 percentage, is carbon monoxide poisoning, because carbon monoxide, you know the reason, it is explained in cyanosis. In patients with headache with autonomic symptoms, in patients with sickle cell crisis, in patient with pneumothorax, severe pneumothorax, before evacuation of the air. So before evacuation of the air, pre-evacuation, you will maintain the saturation about above 96%. You will give oxygen to those patients. So these are the four conditions where you will where you will keep the saturation more than 99 96 percentage: carbon monoxide poisoning, cluster headache, sickle cell crisis, pneumothorax. And remember this one point: mainly those patients who are taking LTOT, oxygen therapy at home, oxygen therapy should never be used near an open flame source, because there will be risk of fire. Okay, so what are the complications of oxygen therapy? What are the complications of oxygen therapy? It can be due to adverse effects of oxygen only. This mainly occurs when the oxygen FiO2 is more than oxygen concentrations are more than 50%, or if FiO2 is more than 0.5. The risk increases with increasing oxygen content in the mixture and with longer duration of oxygen therapy. What are those? Tracheitis, bronchitis, absorption atelectasis. Why? Because you are giving more and more oxygen, nitrogen contained in the lung is washed out. That nitrogen acts as surfactant, which will keep the alveoli open. So when you are giving more oxygen, that nitrogen will get absorbed or get washed out, and the alveoli will get collapsed. So absorption atelectasis is another complication, and acute lung injury due to free radicals generated by the oxygen. Okay, these are the three complications due to high oxygen content or long duration of therapy: tracheitis, bronchitis, atelectasis, atelectasis, and acute lung injury. This is due to high concentrations of oxygen. Okay, effects of breathing a dry and cold gas mixture, especially long term. So you are giving oxygen, but you are not what do you call humidifying that oxygen. So you can have epistaxis, nosebleed, impaired mucociliary transport, mucus retention, and increased mucus thickness, because air will be taken by that oxygen which you are giving. So that will cause increased thickness of mucus. Because of increased mucus thickness, that will block the airway and that will cause focal atelectasis. Bronchoconstriction, you can have reflex bronchoconstriction. And infections can develop because mucociliary transport is gone. Mucus has become thick. There is obstruction. Secretions will pool. Infection can occur. So that is due to breathing of dry and cold mixture for long term. Okay. Third one is restriction of mobility of the patient. An oxygen delivery device hinders the mobilization of the patients. Okay, this is mainly in patients who are in advanced respiratory failure and taking LTOT. So they need to carry oxygen. No, that will hinder the movement of the patients, and that will contribute to increased risk of delirium and falls, because those patients are mostly elderly patients. Okay, now that was about indications of the oxygen therapy, and how do you do LTOT? Give LTOT and supplemental oxygen. What should be the target? And special situations will increase target to more than 96%. And what are the adverse effects you need to keep in mind while giving the oxygen therapy? Now, how do you give the oxygen therapy? First of all, what should be the equipment? In equipment, first we will discuss oxygen sources, from where the oxygen comes. In hospital and emergency oxygen sources, 100% oxygen is supplied in tanks. It is compressed in tanks in liquid or gaseous form. Okay, from the tanks you will get. In non-hospital oxygen sources, mainly used for home oxygen therapy, oxygen concentrators capable of concentrating oxygen from the atmospheric air up to 85 to 95%. So oxygen concentrators are the source in home, and 100% oxygen is delivered through oxygen, liquefied oxygen or gaseous oxygen compressed in tanks in emergency rooms or hospital settings. So what are the delivery devices by which you deliver the oxygen to the patient? So oxygen delivery masks and cannulas. So most common which is used and which is very highly tolerable and comfortable to the patient is nasal cannula, two nasal prongs which are kept in the two nostrils. Okay, a 100% oxygen flow of 1 liter per minute provides an oxygen concentration in the breathing gas mixture of approximately FiO2 will be 24% if you 1 liter. Okay, and if you increase 1 liter by 1 liter, then you will have increase of 4%, as we have discussed before in the previous video. Okay, this is up to 6 to 8 liters only, and this maths will apply only to nasal cannula, not for other things. See this type, this is nasal cannula. Okay, it will, from the ears it will come down and will lock here. Okay, that's about nasal cannula. Others are simple face masks, simple face masks. Okay, so in those masks, from those masks you will deliver the oxygen. But one thing you should remember in this is, when the flow rate is less than 5 liter per minute, then carbon dioxide will accumulate in those masks, and there are risk of rebreathing of that carbon dioxide. So that is the risk in the simple oxygen face masks. If it is more than 5 liter per minute, then well and good. But if it falls less than 5, the flow rate is less than 5 liter per minute, then there is a risk of rebreathing of carbon dioxide. So to counter that thing, that rebreathing of carbon dioxide, there is something called as oxy mask, which is introduced to reduce the risk breathing of carbon dioxide. So what this oxy mask does is, it is here. See, this is oxy mask. This has some diffuser which is located here at this point. So this will throw up a high concentration oxygen on the nose and on the mouth. So that will reduce the risk of rebreathing of carbon dioxide. So that is the difference. And you can see also the FiO2 along with flow rate here, that is given here. 1 liter 24 to 27%, 2 liters 27 to 32%. So that will be helpful for us to calculate, okay, to monitor the patient. So the third one is the Venturi mask. Venturi mask. This uses 100% oxygen at various flow rates. 100% oxygen at various flow rates, and there are different sizes of entrainment ports. What is this entrainment ports? They will have holes like this here. So I will take this here. So Venturi mask will be like this. This is the entrancement port. This of different colors. Okay. So these will have holes in these. So this will take the room air along with oxygen to the patient in the mask. That is entrainment, carrying along with oxygen the room air. So because of different sizes of ports, you will have different mixture of the oxygen, so that you can adjust the FiO2, especially in patients with chronic respiratory failure who are at risk of hyperoxemia. Okay. So for room air to produce precise oxygen concentrations. These masks are recommended in patients at risk of hypercapnia from hyperoxia, high oxygen concentration, because they are mixing the room air with the oxygen. So we'll get some concentration. Okay, as they allow more precise saturation of FiO2. So here it is given Venturi mask. Blue FiO2 will be 24%. Yellow it will be 28%. Blue will be 24%. Yellow will be 28%. White will be 31%. Green will be 35%. 35%. Okay, pink will be 40%. Orange will be 50%. So different type of entrainment ports will have different FiO2. You can adjust precisely. You can titrate the FiO2 precisely, and you will prevent the patient from going into hyperoxia. That was Venturi mask, especially recommended for chronic respiratory failure like COPD patients. Now next is partial rebreather masks. The name itself suggests are fitted with a reservoir bag they will have without a one valve, preventing the mixing of exhaled breath with the pure oxygen in the reservoir. They can provide high oxygen concentrations but are not precise. 70% at 7 liter, 80% at 8 liter, 90 to 95% 9 to 15 liter per minute oxygen. So these are partial rebreathing, means patient will have the exhaled breath. The patient can be able to take partially. Okay. So this is used widely. Non-rebreather masks. These are fitted with same reservoir bag and a one. Here there will be no one wall. Here there will be one wall preventing the mixing of air with pure oxygen. They are enabled to deliver nearly 100% oxygen by preventing exhaled air from entering the reservoir. Okay, I will show this here. See. So this is partial rebreather mask. So 100% oxygen is going, but you will have mixing of inspired and expired gases here. Okay, so you will partially inhale. Okay, here there is 100% oxygen. Here there will be one valve mechanism, so that will throw out the that will throw out the expired air, and but that will not take the room air. That is one valve mechanism. So you will have 100% oxygen in this patient. This is non-rebreather masks. So partial rebreather mask you can use in patients with chronic respiratory failure, hypercapnic, and non-rebreather mask you can use in hypoxemic respiratory failure patients. So this is also important. The next one is HFNCs. What is HFNC? High flow nasal cannulas. The number one was nasal cannula, simple nasal cannula. This is high flow nasal cannulas. So these nasal cannulas with flow rates more than 40 to 60 liter per minute can provide oxygen concentration close to 100%, depending on the brand of the delivery of the device in the breathing gas mixture by using an air oxygen blender, flow generator, and heated humidifier. This is the instrument. These are the instrument of the equipment. There will be blender, there will be flow generator, then there will be humidifier also. They may also provide a slight increased peak and expiratory pressure. What is this peak and expiratory pressure? At the end of expiration, there will be pressure from the HFNC, approximately 4 to 5 centimeter of mercury. So that will help because airway collapse during expiration. Mainly during expiration, the airways collapse. So to keep the airways open during expiration, you will apply some pressure that is known as peak and expiratory pressure. So these HFNCs, mainly this PEEP, in short form it is known as PEEP. Mainly these PEEP are provided by non-invasive ventilation or mechanical ventilation like BiPAP, CPAP, and intubation. But these HFNCs can also provide some kind of PEEP. So that will help in recruitment of some closed alveoli. You can have those alveoli open, and from that respiration can improve. In patients with acute hypoxemic respiratory failure, this can be useful like in acute pulmonary edema, acute exacerbation of COPD, asthma. Okay, HFNCs may reduce the risk of intubation. So you can consider before intubation HFNC, before BiPAP, CPAP intubation, you can consider this HFNC. Okay, so this is the total equipment. So this is the flow meter. Okay, here you will adjust the FiO2 flow meter, and this is the humidifier. The air will get humidified, and this is the nasal interface. You will adjust flow rate from here, and this get humidified here, and this will provide oxygen to the patient here. That's about HFNCs, high flow nasal cannulas. Can consider in patients before BiPAP, CPAP intubation. So how do you know after connecting this HFNC the patient is improving or not? So he'll predict. There is something called as ROX index. ROX index. It is a bedside tool used to predict whether a patient on high flow nasal cannula HFNC for acute hypoxemic respiratory failure, remember hypoxemic, will succeed or fall without needing intubation. Okay. Formula is ROX index is equal to SpO2, nothing but pulse oximetry in percentage, and FiO2 in decimals. You should take in decimals, divided by respiratory rate. Then you will get the ROX index. Okay. So you no need to have if the in limited rural areas, if there are no facilities for what do you call ABG, then you can have this. This is Kigali's modification, no? Kigali's modification. So divided by respirators, you will get ROX index. Okay. So how do you interpret? If the ROX index is more than 4.88, approximately, if the patient on efficiency, if he is maintaining ROX more than 5% approximately, then you will consider that HFNC are doing their jobs. They are enough for the patient. Intubation is not required for right now. Okay. If it is more than 5%, that is a good thing. If it is less than 5%, okay, and the two in less than 4%, if you take less than 4, approximately less than 4%, then there is a high risk of failure. Consider intubation. But if it is less than 5, it is between 4 to 5. If it is between 4 to 5, take approximate values. Okay, then monitor the patient and reassess the patient, especially in acute respiratory distress syndrome and COVID-19 patients. How do you monitor? You will measure at second hour, 6th hour, and 12 hours after starting HFNC. A persistently low or falling ROX is a bad sign. That means you should go for upper respiratory support, like mechanical ventilation. Persistently low, that means less than or between 4 and 5. Persistently the patient is maintaining 4 and 5, or the patient has less than 4, then you should go for upper respiratory support. Okay, if he is maintaining above 5, then that is a good sign. No need to go for upper respiratory support. And the last one is mechanical ventilation. Okay, two types. It can be non-invasive or it can be invasive mechanical ventilation. In non-invasive, it can be continuous positive airway pressure ventilation, also known as CPAP, or bilevel positive airway pressure ventilation. Okay, so in CPAP, there is continued airway pressure. That's why the pressure which is applied is same during expiration also and during inspiration also. That is continuous positive airway pressure ventilation. In BiPAP, what you will do during expiration, you will apply some PEEP. But that PEEP is not equal to the pressure applied during inspiration. That is the problem with CPAP. In CPAP, you can't the pressure which is applied will be both it will be same during inspiration and expiration. But in BiPAP, you can have PEEP. You can means during expiration you can adjust the pressure. Okay. So non-invasive positive ventilation should be an early consideration for patients with acute exacerbation of COPD. This is a very important point because they have a great prognosis with this non-invasive BiPAP, mainly with BiPAP COPD patients, or cardiogenic pulmonary edema. In the absence, these are the contraindications. In the absence of shock or acute coronary syndrome, you should not give this non-invasive ventilation because they will apply high pressure oxygen. No, so if there is shock, you are increasing the thoracic pressure. So blood BP will fall further. Okay, and there will be more pressure on the heart. That's why in acute coronary syndrome it is contraindicated. So you can consider this in COPD patients, exacerbation, and in acute cardiogenic edema, not due to MI. Okay, and also it is in shock patient, you will not use this. It may also be beneficial in other situations of acute respiratory failure. Second one is intubation. You will intubate the patient. You will put some endotracheal tube into the trachea. That is invasive mechanical ventilation. Okay, when a patient no longer requires invasive mechanical ventilation, there is some evidence that the use of HFNC alternating with non-invasive ventilation. Use of HFNC alternating with non-invasive ventilation, nothing but BiPAP or CPAP, may prevent post-extubation failure. So one problem with removing the intubation is many of the patient, mainly elderly patients, will have respiratory failure post extubation. So to counter that problem, this can help. There is some evidence that you alternate HFNC with non-invasive ventilation in risk patients who can have post extubation respiratory failure, like in patients who are aged more than 65 years, or patients who are having chronic heart or lung disease, chronic heart or lung disease, or the patients who are more than 65 years of age. They are at risk of post extubation failure. You can consider alternating HFNC along with non-invasive ventilation. So these are the contraindications for non-invasive ventilation. If the patient has altered mental status, you will not give. Life-threatening hypoxemia, you will not give. Reduced GCS, patient is not able to protect their airway, you will not give. Vomiting, so that is, you will not give the this one, non-invasive. Recent facial upper way or upper GI surgery, fixed upper airway obstruction, you should not give. Facial abnormalities like trauma or burns. Bowel obstruction, why? So because high pressure oxygen is going, so it will enter esophagus also. So if there is bowel obstruction, then that can cause perforation, okay, distension of the bowel. Excessive secretions, hemodynamic instability like shock, undrained pneumothorax. Oh yes, because if you give high flow, high pressure oxygen, that will exacerbate the pneumothorax, okay, which is undrained. Okay, these are the contraindications for non-invasive ventilations. What are the complications of intubation, meaning mechanical ventilation, and how to counter that? You can read this. I'm not going to explain this. Cardiac, just a complication. You will have reduced cardiac. Any patient intubated, that patient will have all these things. Cardiac, you will have reduced cardiac output. Renal, reduced renal perfusion because of reduced cardiac output. There will be salt and water retention, especially when the associated with PEEP. Okay. So there will be reduced renal perfusion and increased salt and water retention. Respiratory, these are the complications. Ventilator induced lung injury because of barotrauma and valvotrauma. Increased volume of oxygen you are giving, increased pressure you are giving, that will cause distension of the alveoli and some kind of trauma to the alveoli. That is nothing but ventilator induced lung injury, VILI, that is called as VILI. So next is pneumothorax, the patient can have because high pressure of oxygen is going, and that can rupture the some alveoli and that can cause pneumothorax. Pneumomediastinum, okay, air in the mediastinum. Pneumopericardium, air in the pericardium. Subcutaneous emphysema, below the skin you are having the air. Ventilator associated pneumonia, this is also a very important recognized complication in patients with ICU, admitted in ICU. Okay, so these are the respiratory complications you should have in mind the patient might have on intubation. Respiratory is over, cardiac is over, renal is over. GI complication, they can be abdominal distension, they can be ileus, paralytic ileus, absent bowel movements. Okay, stress ulceration the patient can have. Yeah. Okay, so what is main two things you should remember when the patient is in mechanical ventilation? Common things is one, stress ulceration, also known as Cushing's ulcer. No, Cushing's ulcer because of stress. So to counter this, you'll give PPS to the patient, and because patient is immobile, he can have DVT, deep venous thrombosis, and pulmonary embolism risk. So for that purpose, you will give subcutaneous prophylactic doses of low molecular weight heparin. These two are the immediate things. Means any patient who is mechanically ventilated, you will give these two. Okay. Neurological complications, critical illness, myopathy, polyneuropathy, others like oxygen toxicity, as we have discussed, ventilation failure or disconnection. Okay, so these are the things. Commentary on this you can read by stopping the video for some time. So you can remember this system wise: renal, cardiac, renal, then cardiac, respiratory, then renal, then gastrointestinal, and neurological. Come from above to below. Moving forwards. Okay, now procedure of oxygenation in acute and chronic respiratory failure. In acute respiratory failure, hypoxemic respiratory failure, supplemental oxygen therapy started in patients should be started only when the saturation falls less than 90%, and considered in those with a saturation of 92 to 92%. So it should be started when the saturation falls below 90%, and it can be consider not mandatory. So if the saturation is above 90%, so less than 90% give oxygen, more than 90%, between 90 to 92% consider giving oxygen. Okay, minimum amount of oxygen necessary should be used to target 90 to 96%, as we have discussed, except those with you are suspecting or confirmed cases of hypercapnic respiratory failure. The target is not 99, it is 88 to 92%. Most frequently, patients of this hypercapnic respiratory failure are patients with COPD, main important, cystic fibrosis, bronchiectasis, post-tubercular sequelae. Okay, kyphoscoliosis, abnormal spine, neuromuscular diseases, obese patients, remember obese patients, to avoid hyperoxia, because obesity is also causes obstructive sleep apnea, it causes chronic respiratory failure, it itself is a cause of chronic respiratory failure. In patients at risk or with confirmed hypercapnic respiratory failure, target is this one. Now you are giving oxygen, you have maintained the respirator, you have sent the investigations, if and you have diagnosed the cause, you have treated the cause. How you will monitor? When you will wean the patient, you monitor the oxygen therapy effects using the pulse oximetry and ABG. Monitor the whether the respiratory support is sufficient, or whether the patient is deteriorating, whether the patient is improving, when to remove. All these information you will get by pulse oximetry and blood gas analysis. If the patient is deteriorating, you will elevate the support. If the patient is improving, you will decrease the support, downgrade the support. Okay. Administration of high concentration of oxygen, more than 50% or FiO2 more than 0.5 is often necessary. Lack of clinical improvement within short periods, HFNC 2, 6 and 12 hours, no, as we have learned now. Within short periods, hours at most, within hours if patient is not improving, it is an indication for HFNC or non-invasive or invasive mechanical ventilation. Okay, like if you are using cannulas, simple cannulas, most commonly which are used, I'm saying simple cannulas or Venturi mask or partial rebreather mask. These are the most commonly used rebreather mask, non-rebreather masks, most commonly used delivery devices. So if the patient is not improving on that, you consider HFNC, non-invasive and invasive ventilation. So that is about acute respiratory failure. Coming to exacerbation of chronic respiratory failure. Do not use empiric without knowing high oxygen supplementation in patients with dyspnea without evidence. For example, pulse oximetry. If you are having evidence, for example, pulse oximetry showing less than 88% oxygen saturation in patient with suspected or confirmed chronic or hypercapnic respiratory failure, exacerbation of chronic respiratory failure. So with the less than 88%, you can give maintain between 88 to 92. But no oximetry is done, then don't give empirically. Okay. So without evidence of eczema before obtaining information on the underlying pulmonary disease, except in the case of life-threatening illness like pre-oxidation before intubation. Most patients with non-COPD or other risk factors for hypercapnic respiratory failure, target saturation is 88 to 90%. So first what you will use Venturi mask for COPD or chronic respiratory failure or acute and chronic decompensated chronic respiratory failure patient. You will use first thing is Venturi mask. Pending the availability of blood gas results. So this has low risk, no, it will miss the room air with oxygen. ABG analysis, less ideally PBG analysis. If low PaO2 values persist or hypercapnia worsens, urgent initiation of HFNC or non-invasive or invasive mechanical ventilation should be considered. Okay. Carefully monitor the effects of oxygen therapy using pulse oximetry or ABG analysis. So these are the two things you will monitor while the patient is on the respiratory support. So this is the summary of our oxygen delivery systems. So in hypoxemic respiratory failure, first you will use nasal cannula in stable patients. Okay. Venturi mask you will use in patients with type 2 respiratory failure or COPD. First equipment. Okay. Partial rebreathing mask you can use in acute hypoxemic respiratory failure like pneumonia, asthma, acute pulmonary edema. I mean, in most acute type 1 respiratory failure, you can use in partial rebreathing mask. So this is in stable patients, not normally stable patients, and this is unstable patients. You can use hypoxemic. Non-rebreathing reservoir mask, severely hypoxemic patient. Okay, like this. HFNC up to 1, acute type 1 respiratory failure you can use. So this is the hierarchy of equipment used in respiratory failure. First you will use either of these two, then you will go to partial rebreathing, then non-rebreathing, then HFNC, then mechanical ventilation. So you have given the respiratory support investigations, everything is done. Now you have some diagnosis. So treat the underlying condition in acute. Treat the underlying condition. It can be pharmacologic, like epinephrine for cases of anaphylaxis, bronchodilators in asthma and COPD patient, antibiotics, pneumonia, acute exacerbation, sepsis patients. Okay, or it can be invasive. like decompression of the pneumothorax, tension pneumothorax, okay, tension pneumothorax especially, or severe pneumothorax, thoracocentrosis in case of pleural effusion, or okay, pharmacologic or invasive intervention you will do as definitive treatment. So this is some causes: pneumonia, ARDS, sepsis, antibiotic fluid, supportive oxygen, COPD oxygen. You have to use bronchodilators, steroids, oxygen controlled oxygen, NIV, asthma, bronchodilators, steroids. Here you have one thing, that is magnesium sulfate. In severe acute severe asthma, you use this magnesium sulfate. Magnesium sulfate in asthma patient. Remember, pulmonary edema, diuretics, nitrates, and treat the cause of pulmonary edema. Pulmonary embolism, anticoagulation, or thrombolysis if severe. If it is not severe, you can give anticoagulation. Neuromuscular, may need ventilator support. Opioid overdose, naloxone, opioid antagonist with airway support is the definitive treatment. Okay. Uh, you will give respiratory physiotherapy, including postural. What is physiotherapy? You will just percuss the chest to remove all the secretions. You will change the position of the patient so that the sputum is easily expectorated, and you will give that respiratory exercise equipment, ball ball exercise, okay, huffing, snuff, huffing. You will teach the patient some procedures like huffing, so that the cough patient can expectorate the sputum easily. All these are the components of respiratory physiotherapy. Nutritional support to prevent malnutrition. Don't abstain the patient from nutrition. Oh, that's about acute respiratory failure and acute and chronic respiratory failure. Now coming to chronic respiratory failure, the patient is not decompensated. This is compensated chronic respiratory failure. How you will treat? So first of all, you will treat the underlying disease. Okay, treat the underlying disease. Oxygen therapy is given during acute exacerbation in hospital, and if there is no acute exacerbation, then LTOT is planned at home, like depending upon the saturation. 90, above 90 saturation, saturation is falling on exertion or during sleep, you plan for LTOT. Between 88 to 90, 89% saturation, three conditions, either of the three conditions, if it fulfills. What are those three conditions? Features of carpal tunnel, pulmonary hypertension, severe polycythemia more than 55% hematocrit, plan for LTOT. Less than 8%, no condition required, give LTOT. Rehabilitation, respiratory physiotherapy, including postural drainage, general rehabilitation, physical therapy, exercise, and education of the patient, and family caregivers, education of the patient also, and family caregivers also. These are the mainstays of treatment. Okay, treat the disease, oxygen therapy, rehabilitation, nutrition support to prevent malnutrition, and LTOT in selected patients. LTOT in selected patients. So mainly the thing which is here is oxygen therapy you should give to these patients long term. LTOT is required for some patients. Okay. So LTOT mostly with neuromuscular diseases and COPD patients. At home, ideally with intermittent non-invasive ventilation or in a clinical setting. Patients may initially require mechanical ventilation only while sleeping, but over time progress to full-time chronic ventilation. That's what I said. No. Now, one thing you should remember, that is, it is difficult to distinguish an acute exacerbation from a chronic progression to end stage disease. So in the later situation, that is, the patient is progressing from chronic progression to end stage, invasive treatments and mechanical ventilation have limited benefit and may cause unnecessary suffering. Ideally, a decision to undertake or not invasive support is discussed well in advance of end stage disease with both the patient and his or her caregivers and consultative body of physicians. So that point you should remember. Differentiate between acute exacerbation and progression from chronic progression to end stage disease. This differentiation is important. This is difficult. Okay. End of life care or palliative care should be an integral part of the care of patients with chronic respiratory illness. Receive, including goal setting, advanced directives, treatment decisions, and psychological support. So, how do you treat the complications in these patients, chronic respiratory failure patients? So, pulmonary hypertension, treatment is oxygen therapy. Right ventricular failure. So, right ventricular failure, treatment is oxygen therapy along with that diuretic therapy, potassium and magnesium supplementation as needed. Treatment for secondary polycythemia and hyperviscosity is again oxygen therapy. Prevent malnutrition, cachexia, proper nutrition is the treatment for this. Proper nutrition. That's about the treatment of chronic respiratory failure patient. Just see the headings of this. So in acute respiratory failure patients, what you do, ABC, then oxygen therapy you will give. Oxygen therapy can be Oxygen therapy can be ABC oxygen therapy, nasal cannula, Venturi mask, partial rebreather mask, non-rebreather mask. Okay, and then HFNC, then mechanical ventilation. ROX index you should remember in HFNC. Contraindications for non-invasive ventilation, complications of intubation, procedure. Okay, how you treat now? Acute hypoxemic respiratory failure. What should be the target? When you should give oxygen? How do you monitor acute hypoxemic, that is? And this is decompensated chronic respiratory failure. When to give oxygen, when not to give? How do you monitor that? Okay, LTOT, when you should consider? This we have not discussed. So oxygen flow should be determined achieve concentration between 90 to 92%. It is given 15 hours, more than 15 hours per day, optimally 24 hours per day. If resting hypoxemia is present, then LTOT is given 24 hours per day. If resting hypoxemia is not there, it is given 15 hours per day, ideally at night. During sleep and physical exercise, you should increase the flow rate by 1 liter per minute. This is LTOT. We have not discussed this. Sorry. Then oxygen support, treat the underlying condition, give respiratory physiotherapy, give proper nutrition. In chronic respiratory failure, treat the underlying disease, give oxygen therapy, rehabilitation, nutrition. LTOT is important component of chronic respiratory failure. Treat the complications. So that's about respiratory failure management. By this we end the respiratory failure topic. Hope you have understood the topic and you have learned from this topic, and hope if there is any correction which is required, do comment in the comment box. Thank you for your listening very much. Thank you.